Oh, but it didn't work. I'll have to use this one. Okay. All right, my job, I was told that I was supposed to figure out how to define high need patients, okay? Or persons, actually. I like that. So I'm going to talk about 6 things this morning. Acuity, chronicity, multimorbidity, timing of specific needs, and scope of needs. I've got 7 minutes. That's 6 things in 7 minutes. I'm going to talk a little bit about data considerations as well. And my assumption is that we are also talking about costs, and I'll have one brief comment per item. So I just want you all to understand that I know how complicated this is. Okay. All right, so severity. It's already been kind of talked about this morning, that persons in the last year of life can, if we define it by costs, be considered high need, at least the way that care is currently practiced for persons in their last year of life. The famous Jerry Riley study that suggested that 25% of Medicare expenditures pay for services in the last 12 months of life. Obviously a hugely complex issue, but I think that if you're going to try to crack this nut, addressing care in the last year of life could benefit both the cost curve, but also more importantly, frankly, the way that people view the quality of their last year of life and meeting patients' preferences. Okay, chronicity. Conditions that require ongoing interventions to prevent complications or reduce the rate of physiological functional declines, or rarely cure them. Think about the hepatitis C drug. Now, a very high cost drug. When to initiate treatment is a question, but that's one that may be happening more often as we find more drugs that can treat some chronic conditions. But my question here is, are sometimes the treatment costs warranted? And I'm going to use the case of multiple sclerosis, MS. Disease-modifying treatments, or DMTs, have been available for MS since the early 1990s. And the evidence suggests that they are only effective for people with relapsing remitting disease in terms of their ability to slow functional declines or decrease flares. Greater than $60,000 per year is the cost. But we now know that about 63% of people with secondary progressive form of MS, which is the most common form of MS, are taking these DMTs with no evidence of benefit, because they really just hope that they'll work, but there's really no evidence that they will. What do we do with this? Do we match patients' preferences, or do we try to educate people about science and benefit? Okay, tough one. Okay, multimorbidity, we've already talked about that. Melinda teed up the Commonwealth study of people in 11 countries who are age 65 and older, found that 68% of Americans have 2 or more chronic conditions, 53% take 4 or more medications, and we are, in fact, the highest percentages of both of these measures among the 11 countries. But I was told before I was talked to during my little phone call about what my talk was supposed to be like, that somebody would already have talked about the fact that physical and mental health needs cannot be separated. And so here I am, the 8th time that this is mentioned. Physical and health needs cannot be separated. Okay, they're really, they magnify the expense more than twofold. Okay. All right, so this has already been talked about a little bit, but I'm just going to emphasize this again. And that is that some high-cost needs might be single events or happen only periodically. So there's going to be some level of predictability about that, but maybe not. So for example, costly surgeries, such as transplants. We know that those patients in a particular year, our speaker from Stanford said that $1.5 million for the heart transplant. That will be followed for the ensuing years of that person's life with somewhat predictable costs, such as immunosuppressive therapy, but also complications that may or may not occur, but have some certain probabilities that maybe you could calculate. But let's go to something that's totally different, like equipment purchases. Did you know that a rehab wheelchair that has all sorts of electronics on board that allows people to tilt and lift, and so prevents, to the best of our capabilities, the pressure ulcers that Jeremy talked about earlier? A rehab power wheelchair can cost more than $40,000. Now, Medicare rules allow a purchase once every 5 years, and so that will be a somewhat predictable cost, but that population, you can expect that that is going to be an expense that you will have at some particular point. Okay. So when we talk about high costs, we're thinking about cost to whom? Okay, so if we talk about cost to the insurance payer, people with disabling conditions are going to require a variety of services that are sometimes paid by insurers and sometimes not. And so what is covered by the insurer is going to determine whether something is a high need. I'm going to talk in a couple of minutes about my work with Commonwealth Care Alliance and Bob Masters. Bob, are you here? Yeah, there he is. See him. You're going to hear him later this afternoon. I will, reveal right now that I'm on his board of directors, so there's a little conflict there. But from what I know a lot about some of the really high cost patients is from working with Commonwealth Care Alliance on their duals demonstration project right now. And what we are finding is that housing is the biggest problem for the population that we're serving, housing. But our dual payments from Medicare and Medicaid do not allow us to directly pay for housing vouchers. So what do we do? Okay, but all right, so maybe there's some things on the edge of housing that, that insurers will pay for. For example, will they pay for ramps so somebody can get in and out of their house? Will they pay for an accessible bathroom that has a roll-in shower and has a sink that somebody can roll in underneath so they can wash their hands? Or this is my friend Michael, who has primary progressive MS and is perfectly happy to have me take his picture and show it, because a picture is worth 1,000 words. When he knew that he was going to need this at some point and he renovated his modest little home, he spent $7,000 installing ceiling-mounted lift devices. You see those two hooks there? Those hooks are put under his legs by his aide, and so his aide can lift him from his chair to be able to move him into the hospital bed to his right. Obviously, these kind of accommodations and adaptations in homes support the independent living and benefit both persons with disabilities, but also their formal and informal caregivers. But are these costs covered by insurance? All right, so finally, my last point is data considerations. Nobody's actually said these words yet, but the International Classification of Diseases, the ICD, ICD-9-CM and ICD-10-CM, can we convince ourselves that they really tell us anything meaningful about functional capacity or functional impairment or disability? I don't think so. So now other measures of frailty and disability can come from surveys and clinical assessments, but frankly, I'm actually of the belief system that there are cultural biases built into some of our surveys and some of our measures of frailty and even some of the clinical assessments, and there's also a gaming potential. So once payment starts to be based upon this, guess what? The worms are going to come out of the woodwork, and we're going to see some gaming there. And again, building from some data that Bob, after my pleading with him last week, generously gave me, that using diagnosis codes from claims may not capture the health of persons who have not received adequate care. So the Massachusetts OneCare program, just a couple of minutes about it. It's a dually capitated program for Medicare and Medicaid enrollees ages 21 to 64. And so by definition, these are all people who qualify for Medicare because of disabilities. It capitates both the Mass Health Medicaid program based on, and Medicare, but the Mass Health capitation is based on rating categories. And the rating categories for Mass Health were initially assigned based on Medicaid claims for participants from the prior year. So people didn't get services, there wasn't any claim. All right, so here's a really busy slide. This is the Mass Health rating categories. At the bottom, lived in facility for greater than 90 days, only like 0.01% of people. The rest of people are trying to be community living people. The tier 2 people have high behavioral health needs, and you can see there that the tier 2B also have substance use disorder along with that. And then the tier 3 people have a kind of complex definition having to do with ADLs and skilled needs. But these are people who have major physical disabilities generally, and then the 2B have selected diagnoses with very high costs, like amyotrophic lateral sclerosis or spinal cord injury. All right, so once OneCare started on October 1, 2013, it became really obvious that enrollees had higher needs than their assigned rating category. they had not had the Mass Health claims from the prior year to support the higher assignment because they hadn't received the services. So Bob and his colleagues very cleverly spoke to the people at Mass Health with data, with a lot of background information, and they said, look, we need some help here. We're just not able to provide the services we can because we're just not getting paid the capitated amount that we need to. And so on this slide, I show you the initial rating from the Mass Health claims, and then the upgrade that is based on the functional status assessments that were done after these people had enrolled in the CCA OneCare program. And so you can see that initially 59% of people were C1. That's kind of the minimal care level for this high-level care population. With the upgrade, it was only 40%. But look at what happened with the C3s and A's and B's. We went from about 20% in the initial rating up to 35%. And so it's only because of the upgrading in the rating category that the reimbursements more closely match the high costs, especially for the C3 enrollees who need the considerable in-home and community-based services and supports that allow CCA to continue to provide those services. Okay, so I talked really fast. This was a drop in the bucket, but those are, sorry, that was my drop in the bucket. I'll be happy to answer any questions. Okay, you're welcome.